Hi, everyone. Thank you for joining me on today's episode of Ask the Egg Whisperer. And I have a really cool thing that someone gave me today that I'm going to share with you. It is freaking hilarious. I don't do pole dancing, but apparently I do today. So this is cute. Other fertility doctors and then you, and that's me pole dancing. Apparently I'm a unicorn, a sparkly unicorn with a rainbow mane. So super fun. So that's why I thought I'd channel some sort of like ponytail. Get it? Ponytail? Haha. Okay. Well, thank you again for tuning in. I'm going to start answering your questions right now. The first question is from Samantha. And Samantha is saying, we're preparing for our 4th round of IVF with ICSI due to male factor and are having a difficult time making quality blasts to freeze. Our 2nd round, all 3 were sent and were abnormal. And our 3rd round, out of 16 retrieved, 8 mature, only 5 fertilized, 2 stalled, and the others couldn't win the beauty contest to biopsy and freeze. What supplements can we take to improve our egg and sperm quality? Do you have any knowledge on olive leaf extract? My husband is taking this as well due to antioxidant effects. Okay, so Samantha, there's one thing I just don't know about you, and that's your age. So I don't know if you're watching right now and you can just put up your age for me. I'll just sit here and wait as I grab some of the supplements here to talk to you guys about that Samantha's asking about. And that's okay if you're not there. No problem. So here's one supplement that I love, and it's True Niagen. And again, like you can buy it from any company. NAD is the name of the supplement. And then the other one is something like this, Pterostilbene. So these two together with CoQ10, I think can help egg quality. And it can actually improve sperm quality as well. So talk to your doctor about whether they think that could help you, but that's what I would consider doing. I mean, you've done 4 rounds and it sounds like you know the diagnosis, and make sure when it comes to the sperm that you looked at sperm DNA fragmentation testing. I did a show with Dr. Blake Evans. So in that show, go to that podcast and listen to it. And what he talked about was having a higher rate of blast formation from extracted sperm. Yes, I did just say that. So extracted, just like you extract eggs from an ovary, you can extract sperm from a testicle. So talk to your doctor to see if that study could somehow help, and the study findings can help in your situation. So that's kind of something that I would think about doing if you were a patient of mine too. And make sure you've gone through the balls method, see if there's a varicocele, look at lifestyle, put the sperm through a fitness challenge. You know what I'm talking about, like little sperm cell lifting dumbbells or whatever. Clearly I don't lift weights because otherwise I would know what I was talking about when it comes to that kind of stuff. So Samantha, I wish you all the best, but I really think thinking really deeply, I don't know how you can think deeply about sperm, but diving deeper into the sperm situation and the diagnosis and why it's like that, I think could probably give you the answers as to why the embryos have stopped growing. I think as women, so much of what happens, we think it's our fault, and we internalize it and think that it might be an egg quality issue. But having 16 eggs, even though 8 were mature, I don't necessarily think that you should feel like it's all you. But talk to your doctor about what you can do to maximize the number of mature eggs, grow the eggs a little bit longer, a stronger trigger shot dose, maybe adding HGH, that can help too. So now I'm going to go to Erica's question. So Erica said, hi, Dr. Aimee. I'm 30 years old and was born without a uterus due to a condition called MRKH, Mayer-Rokitansky-Kuster-Hauser syndrome. However, I have healthy ovaries. Though I don't menstruate, I still ovulate each month. I just began the process of egg retrieval and my labs came back normal, and I'm good ovarian reserve with an AMH of 3. However, my follicle count measured twice at different times in my cycle was quite low. Only 2 to 3 follicles. Is there any reason that my AFC and AMH would be mismatched? Is there something I can do to help improve my follicle count in the future? Thanks a lot. Okay, Erica, so this is the thing. If you have MRKH, my question to you is, are they really able to see well with a vaginal probe? Sometimes you actually need to look abdominally. And the other thing is that, is your AMH truly a great reflection of what's going on? And the only way you would know is if you repeated it. So if your AMH is still high with a second draw, then I bet that you have more eggs and they just can't see them. Alternatively, the other possibility is you're one of the 1 in 5 whose AMH and AFC just don't make sense. And that's another way of saying that the AFC doesn't always predict the AMH, and the AMH doesn't always predict the AFC. And so the AFC is what I would go by as far as how you would predict your IVF pyramid would look for you. And for those of you who don't know about the IVF pyramid, it's the IVF rate of attrition from the number of follicles you have up until the embryo that ultimately is the one that turns into a pregnancy. And I always tell people to know what your pyramid looks like, right? Know what the size of the follicles are, what the pyramid looks like. Are you happy with what's going on, when the retrieval is going to be? Should you keep going? What does the lining look like? What are the estrogen levels, right? So those are the things that I find are really helpful for me to talk to my patients about, and for you to know as you're going through this process if you're an IVF patient. But it's not an unusual thing to have an AMH of 3 and then have a low egg count, and you're just like, what the heck? Like, I'm supposed to have a really high egg count. And that's why it's so important for you to get your, not just levels checked, but get your ovaries looked at too. So don't just rely on the AMH. Looking at the AFC is truly often a better guide as far as what your expectations should be. That should be like a song. I'm sure if I tried, I would not be able to do that again because that kind of rhymed a little bit. Okay, so this next question is from Vrushali, and Vrushali says, I had 2 natural pregnancies resulting in ectopic pregnancies, and my tubes were removed as a result. I started with IVF and it resulted in 3 embryos that were blastocysts. The first transfer resulted in a stump pregnancy terminated by methotrexate. Later, I had a laparoscopic procedure to close the gap created by the tubal removal. After that, a failed transfer. We did ERA after that, and the last transfer also resulted in failure. We have not done PGS testing. What else should we consider? So Vrushali, first of all, I'm sorry you've been through so much. Surgery after surgery, and then another ectopic after the 2 ectopics. It's just like, what are we missing here? So again, let's just dial it back and just talk through diagnosis before treatment. So obviously there's a tubal issue. So the question is, why? What is up? Like, what's up with the tubes? Literally, like, why are they doing this? So the why could be endometriosis. And the endometriosis could also be causing the transfer, having a lower chance of working. So ask your doctor, what have you ruled out? And is there a chance that what's going on with me could be related to endometriosis and adenomyosis? Because if that's the case, it sounds like I just swallowed a frog. So I'm going to take a sip from my awesome mug that someone gave me. So cute. And now I will keep talking now that I don't sound like a frog. So back to Vrushali's question. I'll keep talking about endometriosis. I think it's important to always talk about what's the diagnosis and make sure we're not missing anything, because if the tube was the issue from the beginning, we want to ask why the tube was causing these issues and what else are we missing? Are we missing a need to treat for endometriosis and adenomyosis? So Vrushali also asked, we did the ERA, and after that also didn't work. And the only thing we haven't done is PGS testing. What else should we consider? So I would consider doing another IVF cycle. I would consider PGS testing if your doctor thinks it's a good idea for you. And I would also consider doing a test for endometriosis, like the Receptiva test. And then ask your doctor, say, hey, when you did the laparoscopy surgeries for me, did you see any signs of endometriosis while you were there? And ask them about it. And if there were any signs, then talk about treating it, okay? So this next question is from Jen. And Jen says, hi, Dr. Aimee, thank you for what you do. I was diagnosed in May of 2019 with POF. For those of you who don't know what that means, it's premature ovarian failure. And you guys know my personality a little bit by now, that I don't like the word failure. So the other term we use is primary ovarian insufficiency, and that just kind of seems a little less negative than the word failure, but I'm going to keep talking about what's going on with her. Before my hubs and I even started trying for our first baby. I'm 38, FSH is 20, AMH 0.019. My doctor at the time wanted to fast track me to an IVF cycle with donor eggs. Told me it would be very unlikely I would be able to conceive with my own eggs, and I was not comfortable rushing into things so quickly. I've changed doctors, did a lot of lifestyle changes, diet, acupuncture. My cycles are all over the place, anywhere from 22 to 70 days. My acupuncturist just started me out on some herbs. My doctor wants me to have a karyotype to rule out Turner syndrome. Her question is this: do you have any experience with this? And my question is, if I have it, How will it affect my outcomes, whether it be getting pregnant naturally or IVF? I have not done IVF yet. I'm too scared. Thank you so much. Okay, so Jen, you're right. Going through this at 38 is on the early side, but it does happen. So what I would do if you're a patient of mine is I would do this. I would do a chromosome analysis, and if it's abnormal and it gives us an answer, we may not continue trying with your own eggs, okay? If you're a carrier for Fragile X, that's the other thing that we would do. Same thing. We may not decide to move forward with your own eggs. However, there are other things that potentially could cause this that are not genetic, well, kind of genetic, because you can inherit autoimmune issues or, variants that put you at higher risk of acquiring them or developing them. And that would be to look at anti-thyroid, anti-adrenal, and anti-ovarian antibodies. So I'm not sure if in your family you have any family members that have any autoimmune issues, but ask your mom when her menopause was. If you have sisters, ask them what's going on, and then see what your antibody levels are. And what I have found, and one day I'm going to publish this, and I know I'm not like the only person that's discovered this, but I find that in women who have, let's say, anti-ovarian or anti-adrenal antibodies, if I treat them with a steroid called naltrexone, the antibody levels might be improved, especially the anti-thyroid antibody levels, and women start ovulating, their FSH levels come down, and it's just nuts. I've probably seen this in about 5 patients, and their cycles go back from like being sometimes totally absent to starting up again. So I would recommend doing a little bit more testing, and then anytime you have an egg, see what you can do to extract it. So when your AMH is 0.01, it means that you probably don't have even one mature egg that can be retrieved. But if it were me, I would have a hard time having closure until I really felt I understood what the diagnosis is, and I really felt that someone gave me a chance and believed in my fertility. It sounds like you found someone who does, because they're doing extra testing and you switched doctors, and sometimes that's what you need. But at the end of the day, I think it's really important to keep showing up. And what I mean by that is you never know when you're going to have a chance to maybe ovulate more than one egg. So, as a patient, as patients of mine who go through what you're going through, I'm literally like, so what are you doing tomorrow? I'm like, come on in, let's take a look at your ovaries. Okay, what can we do? What are your levels? What kind of meds can I put you on to maybe, I use the word trick your ovaries, to wake up and maybe give us an egg. So I hope that helps you too, Jen. So this next question is from Vicky. Vicky says, what's in your supplement toolkit? Toolkit, not toolcut. Toolkit. I've heard you reference a couple of things real quickly on the show, but I couldn't catch what you said. Okay, Vicky, thank you for watching today. I'm going to hold it up. This is True Niagen, TRUNIAGEN. I have zero business relationship with any of these companies. That's one. And then this one is pterostilbene, PTEROSTILBENE. That's the other one. So there you go. Next question is from Dio. Dio says, my AMH is 0.08. I'm 42. Partner's a few years older, almost 50. His motility is not that impressive. I think it's because of his age. We've been trying to conceive for over 3 years. We've tried a few IUI attempts and are yet to embark on IVF, as I know many fertility doctors are not really keen on moving forward with such a low AMH. I feel that low stimulation may be the better option given my situation, yet many fertility doctors I spoke to are still suggesting a high dose given my age. What I don't like about IVF is its overstimulation. Why do doctors always prefer such high stimulation when I understand that the first IVF baby born was without stimulation? What's your advice for us? Okay, so here's my advice. Diagnosis before treatment, what's the story? We're 42 years old with an AMH of 0.02. What does that mean for us? Okay, so what that means is the likelihood of getting one egg is probably less than, let's say, 5%. So 0.08 means maybe one egg, right? Maybe. But at the same time, if the motility is really, really low, the likelihood of getting pregnant naturally at home or with IUI is probably less than 5% too. So you are someone that might need IVF to get pregnant, no matter how many eggs you had. So ask yourself this question, and you guys know the question. The question is, do I feel like I need to go through IVF to have that experience before I can move on with other options? Because your AMH suggests that you're a very normal 42-year-old, and most of us don't have healthy eggs left. I know that's hard to hear, but a very small percentage of women at 42 can get pregnant. Each egg has, let's say, once it's an embryo, maybe a 15 to 18% chance of being a healthy embryo. And so if I'm saying maybe one egg, you're saying maybe a 15 to 18% chance if it's an embryo, but the likelihood of getting that is really low. So, you've already been trying for 3 years, over 3 years, you're 42, you're young. I want you to be a mom now. I don't want you to keep going to fertility doctors and doing IVF or IUIs or treatments that don't work. Let's talk about pragmatic and practical things that will really help you be parents. That's kind of my thought. So I hope that helps. Next question is from Stephanie. Stephanie says, "Hi, Dr. Aimee. Thank you for sharing your time. When I was 38, I did a retrieval, and out of 10 eggs, 5 turned into 5 PGS tested normal embryos. 10 months later, this is what happened. At 39, I did a second round, and out of 12 eggs, I got 1 normal and 2 low-level mosaics. I've yet to transfer because of a thin lining and COVID. I'm worried I don't have enough blasts to be successful because of my thin lining, which may decrease my odds of implantation. Should I continue to try for more blasts or try to transfer? I'm currently preparing for an ERA test." Okay. So it seems like you have, based on what you're sharing, 6 PGS normal embryos and 2 low-level mosaics. So talk to your doctor about the embryo diamonds. Remember that mnemonic, you guys? So the diamonds, each letter of the diamonds represents what you need to know before you transfer. Everything you need to know about your embryos, right? So I think of embryos like beautiful diamonds, right? They're sparkling, they're beautiful, and every embryo is going to be a little bit different. So you want to know what day your embryo is frozen, the implantation rate per embryo, which one's abnormal, which one's mosaic, which one's normal. Get all the official reports. Will these embryos help you reach your dreams and goals, just like you're asking me right now? And what was the sperm on the day of the egg retrieval? So sit down with your doctor, print out the list, and go through each and every one with your doctor. And then you can truly answer that question, should I do another IVF cycle? Because if all the embryos, let's say, are very low quality and will give you, let's say, a 10% chance of a healthy pregnancy, then yeah, if you want more than 2 kids especially, you might want to do another cycle. Otherwise, you certainly might have what you need. As far as the thin lining, I have one tip for you. The tip is, ask your doctor if there's a chance the ERA test could affect your lining and make it, harder to thicken in the future. What I mean by that is typically an endometrial biopsy has a very low likelihood of causing a thin lining, right? So it's a traumatic procedure. It lasts about 3 to 5 seconds when we do it. But in people who already have a thin lining, I'm just going to share with you my approach. I don't do the ERA test, right? Because I'm very concerned that patient might have a very sensitive lining, and doing the ERA test might cause their lining more harm than good, right? So the good is getting the information about the ERA test, but if you're doing a test that's going to result in a thinner lining, that doesn't seem that it would be that helpful, because a thicker lining to me is more important than having a result from an ERA test, especially in someone who's never transferred before. So talk to your doctor about perhaps doing a hysteroscopy, saline sonogram. Ask them what your lining was on the day of the trigger shot for your 2 IVF cycles, because you might be a better candidate for doing a natural cycle transfer. So these are all the things that I would talk to you about as a patient of mine, and also suggest things like aspirin, vitamin E, L-arginine, looking at your body size and lifestyle, and anything and everything we can possibly do to get that lining nice and juicy and plush and have it be the bounciest of bouncy houses for that embryo as it lands into the uterus and it starts jumping around. I saw a couple jumping babies in people's uteruses today. Uteri. Okay. This next question is from Catherine. Catherine says, "Hi, Dr. Aimee. I'm 44 years old, and because life doesn't always turn out the way you had planned, I'm only now trying to have a baby." Well, Catherine, honestly, you're pretty average to me as far as what goes around in the Bay Area. Most of my patients are coming in between 41 and even 47, starting their family for their first baby. So, I would say that don't shame yourself. My AMH is 1.09 and FSH 22. Everything else came back normal. My doctor suggested I use an egg donor, as my chances of getting pregnant with my own egg are about 1%. Hearing this was devastating, and I wasn't ready to go down that road yet. My blood work shows that I'm ovulating. I've taken letrozole for 2 months with a trigger shot, and they just suggested I try IUI next time. My insurance denied the coverage due to my FSH level and age. What are your suggestions? Should I try IUI? Is IVF at this stage even an option? Catherine, it is. It is like immediately. So with your AMH, my guess is that you have a really healthy egg count, okay? So get your antral follicle count checked, and if it's really as high as it seems, go right to IVF and do it right away. And go to a doctor that believes in your fertility and will help you as soon as possible. As far as doing Femera and IUI cycle, that could definitely work. I've seen it work. I've had patients 44 years old get pregnant with fertility pills and shots with IUI. But my approach would be for you to strongly consider being as aggressive as you feel comfortable being. And if IVF just financially doesn't make sense for you for the low chance, then take more medication to help you ovulate more eggs than just a low dose Femera protocol. Consider a much higher dose Femera protocol with fertility injections to get maybe like 4 to even 5 eggs to grow. I know it's like, what? I don't want quadruplets, but that's what it takes to help someone who's over the age of 40 get pregnant with one. So what the studies show, and I did a podcast with Dr. Blake Evans on a different topic, looking at ovulations and the number of eggs ovulated and the twin rate. And it seemed that women over the age of 40, you really don't increase your chance of twins unless you ovulate, over 4 eggs. Okay. So I don't worry about that stuff. The only thing I worry about when I help someone ovulate more than 3 eggs, especially, is the pain, bloating, and discomfort they'll feel after ovulation. This next question is from Jordan. Jordan says, hi, thanks for what you do. I'm 36. Blood work is mostly normal, except my FSH is 9. I have an AMH of about 2.5. HSG showed tubes are open, but the uterus and ovaries are to the left. Okay. They did not express concern about endometriosis. We've been trying to get pregnant for 1.5 years and have had 6 unsuccessful IUIs. We just completed 1 IVF cycle. I had 16 follicles, 9 eggs, 8 fertilized, 5 made it to the blastocyst stage, and 1 came back normal after PGS testing. Given my AMH, I was kind of expecting more eggs, and given my normal carrier testing and my husband's super sperm with 98% motility, as my doctor likes to call it, we were not expecting the PGS results that we got. I was on birth control for a month and Lupron, 75 of Menopur, 375 of Gonal, and we're doing another round. But is there anything you'd suggest related to the med protocol or testing for me or my husband, or any other thoughts? Thanks. Okay, Jordan, this is the thing. I think birth control pills are awesome. They help with IVF planning. I think of them as IVF planning pills. But some people, their ovaries just don't respond as well, and you don't get as many mature eggs because of birth control pills. And I'm not just saying something because it's just me just talking and this is my experience. This is like what happens. We just know from studies that birth control pills can suppress the ovaries and make it harder for them to wake up. And I truly feel like in some cycles, you could get less mature eggs because of them. Is that the case? Is that what happened in your situation? It's possible. I mean, I won't know for sure, but that's one strategy to consider with your doctor, is consider not using birth control and not using Lupron. You're someone with double-digit eggs, right? Like, let's use an antagonist protocol so we can trigger you with Lupron if needed and HCG. So I hope my suggestions will help. And some people think, including me, that HGH might increase the number of mature eggs. So I hope all my suggestions are going to help you, Jordan. And of course, you know my supplement, we'll call it my special sauce, taking the CoQ10 prenatal with vitamin D and fish oil, and then taking the other stuff that I talked about earlier on this show. So thanks, Jordan, for your question. I hope your next cycle gives you more PGS or PGTA normal embryos. This next question is from Zoe. Zoe says, hi, Dr. Aimee. What advice do you give your patients in the lead up to a frozen embryo transfer? What can I do to try to improve the thickness of my lining? I'm on aspirin, estrogen patches, I'm drinking pomegranate juice, red raspberry leaf tea, and I'm also doing castor oil packs. I'm taking vitamin E, L-arginine supplements. My doctor also advised to do exercise to get blood pumping around my body. Is there anything else I can do? Okay, so I don't know that you're telling me that you even have a lining issue, right? So I think so many people are worried about having an issue that they don't have, and I totally get it. Those ants, the always negative thoughts that are constantly coming into our head, it's like, just stop it. So if you don't have a problem, let's not worry about a problem. But if your doctor has shared with you that you have a thin lining, the other things I would suggest that you add is maybe it looks like you are taking aspirin. No, maybe. Oh, you did. You did mention aspirin. You did mention vitamin E. You did mention L-arginine. The other thing that you can consider doing is estrogen shots instead of the patches, and then ask your doctor what your lining was at the time of the trigger shot and see if, using your own body's estrogen to thicken your lining, maybe that would help instead of just the patch or the shot. So it sounds like you're doing everything you can possibly do, honestly. And then the other thing that you didn't mention is acupuncture. I mean, I actually talked about an acupuncturist today as a, I won't tell you what I called her. I mean, I adore her, don't get me wrong. But I usually just tell my patients, just go in there and tell them, work your magic. I have no idea how they do what they do and why somehow acupuncture can help thicken the lining of the uterus. But, sometimes it can help. It certainly can only hurt if you hate it. So if you hate it, don't go. But if you love it, go. And maybe that will help too. So now I'm going to move on to Connie's question. And Connie says, hi there, any other protocol option for me? And here's what she shares with us. I'm 41, met my partner later in life, and I had stage 4 endometriosis since my early teens. I've had 2 laparoscopies, decreased ovarian reserve, and I was told I would have 1 chance of IVF to use my own eggs. I was put on a flare protocol, max dose Gonal-F, and started with 75 Luveris, and now I bumped up to 150. I'm not responding well. I'm on day 10 of stems and only have 1, maybe a total of 3 follicles on the left, none big enough on the right. I am told to start considering if we want to cancel this cycle. I also use androgel as part of this, no DHEA. In Canada, we need a prescription for this. And I've done acupuncture for 2.5 months, fertility massage. I'm on all the supplements, eating clean. Is this my only chance? Do I need to cancel or do I go ahead and hope and pray for the best? Is there another protocol you would do after this for better outcome? My clinic thinks this is just how I will respond and to look at donor eggs next. Okay, Connie, this is how I would help you make the decision. Let's see what your AMH level is. If your AMH is like 0.1 or 0.2, this might be the best. If your AMH is like 0.4 or 0.5, then I would say, let's wait for a better cycle. Let's hold off. Let's use this cycle as a learning experience and see what would happen next time. And if next time you have maybe 1 follicle and we want to take a chance, go for it. And it's not like there's an emergency here. Your eggs don't disappear overnight, although it feels like it sometimes. And let's just see what the next cycle brings. And even if you choose to not move forward with IVF the next cycle, remember this. You never can look back and say you didn't give it your best shot. And you can never look back and say you didn't do IVF. I mean, you literally did IVF. You may not have gotten to the egg retrieval, but I think so often people go into an egg retrieval because they feel like they need to feel like they did IVF before they move on to egg donation. But I always tell my patients, look, let's use this experience and then feel like, yeah, I did IVF and it just didn't work for me. And then let's move on to something that's going to work really well, if that's acceptable to you. But only you will know when you will have IVF closure. And some people need to have that experience of going through an egg retrieval before they can move on to the next step. But I would say with stage 4 endometriosis in your teenage years, and now at 41, we know what endometriosis does to our eggs. And I would say one of the things that I worry about being on all those hormones that you're on for so long is that it can cause endometriosis to grow back. So I would be really careful with the hormones that you're on. And the one thing that I would do if you were a patient of mine is use letrozole and try to use letrozole, let's say 4 tablets per night for 5 nights, then add the Gonal-F, right? And then see what we get from there. So a more, I'll use the term mini IVF or natural approach to IVF for you to see if we can get at least 3 eggs to grow. That would be my suggestion for you. So this next question is from Katie. Katie says, hi, Dr. Aimee. Thank you so much for your efforts in helping people, not only your patients, but people around the world in creating families. Thank you, Katie. That's very sweet of you. I'm 45 years old and single. I tried IVF 3 times since the age of 39, not consecutively. Last attempt was 3 years ago. All failed, none sticked. Do I still have hope to have a successful IVF? Should I try again? I'm looking forward to hearing from you. I hope to hear from you. Best wishes to you and your family. Katie, thank you for being so kind. Thank you for listening. And thank you for doing all the wonderful things that you're doing to be a mom. And my goal is to help each and every person be a parent who is watching and listening, and anyone who doesn't even know about me. Like, obviously, you don't have to be watching, listening, or asking me questions for me to really want you to be a parent. But I just feel like my one job, like here on this earth, while I'm here, is to make sure that I leave this place a better place, right? Than how it started before I was here. And the one way that I can do that is by helping people who really want to be amazing parents, be parents. Okay. So Katie, this is the thing though. At 45, it's the same thing that I told Connie. You can never look back and say you didn't try your very best, ever. You did 3 IVF cycles since the age of 39, and you're young, you're 45. I think it might be time to say, you know what? I think I'm going to do something next that's going to really give me a high chance of being a parent. And doing IVF at 45 after 3 IVF cycles that didn't work, that probably isn't going to be it unless you start thinking about other more creative family building options. And there's so many wonderful therapists like Jana Rupnow, Rupnow. You got to go to her Instagram page if you haven't heard of her before and just follow her. And just the way she talks just makes us feel more comfortable about the concept of donor-conceived children and having a donor egg baby. And I offer my patients egg donation, embryo donation. We talk through adoption resources. So it sounds like you're going to be a great mom. And I just feel like you've spent the last 6 years trying to achieve that goal. And I just feel like there's no better time than now to consider other options. And I would say it might be a good time to not do another IVF cycle. But if you still feel like you really needed to have IVF closure, find a doctor who feels really comfortable and will give you a very positive experience. Because after everything you've been through, I don't want you to be so depressed or anxious or triggered that you're just done, right? So I want you to feel really good about the experience so you can truly feel like you were listened to and you were given the best chance for pregnancy. Because honestly, guys, listen to this. I mean, if a 45-year-old man was like, yeah, I've been trying since I've been 39, I want to try again, we would be like, sure, let's do it. But when it comes to women, we're just like, huh? Like, why would you do that? So that's just not my style. So my style is to listen, to make sure my patient's priorities are mine, to apply my rule of honesty and transparency to every single case, and to be kind of annoyingly positive, but also practical and pragmatic at the same time. So Katie, I believe in you and I believe that you know deep down like what you need, but I would say talk to the therapist and talk through those 3 questions with that therapist. What do I want? What is it going to take to get what I want? And what am I willing to do? Am I willing to do it? That's the 3rd question. So you guys write this stuff down, like, or type it out and just really look at it and go into a lot of detail about all these things. And then you'll come up with a really nice plan for yourself. Okay. So I'm going to go on to Jade's question. Jade says, hi, Dr. Aimee. I completed my 2nd round of IVF. My AMH is 2.99 and I'm 42. I had a tube removed due to a cyst and my other tube is blocked. Jade, I'm going to have a little swig of my water here. In the first cycle, I got 9 eggs, 6 fertilized. On day 3, all were okay, but at day 5, I put 1 back in fresh, and at day 6, I froze 1, but neither of them worked. In the 2nd cycle, 12 eggs, 11 from just 1 ovary, the left one. The other one just never the same from the cyst surgery. I had 8 mature eggs, 6 fertilized. On day 3, they put fresh 1 in, and day 5, only 2 were still growing, and the fresh one didn't work. If I do another cycle, what should I do differently? It must be egg quality. I'm on CoQ10, multivitamin, vitamin D, magnesium, vitamin C, NAC, lipoic acid. I'm trying to hold on to hope. So Jade, that's why you keep showing up. That's why you sent me this question, right? It's because you're a very hopeful person. And I think that's what makes us human. And that's what like most fertility patients have in common with one another is there's still that belief that you still have a good egg left in terms of people who are trying to conceive over the age of 40 who've done multiple cycles. So this is how I would approach a case like yours. I would say, I'm going to think of doing IVF as work, right? And not emotional work, like not like the work that I do. Okay, I'm just going to put in the work. But I have to say the following things. It can take 4 to 6 IVF cycles for a woman who's 42 to even have 1 healthy embryo. And even if I had all the money and resources in the world to see the very best doctors, there's no doctor that's a medical deity. We're just medical doctors. We can't change the DNA of what's here, and it might be too late to have a pregnancy with your own eggs. That's really hard to hear because we are conditioned to think that if we believe it, we will achieve it, and if we work hard enough, we'll get there. But that's the I'm going to use a bad word, you guys. So if you're like don't want to hear a bad word, tune out. But the shitty thing about being a fertility patient is those rules that we can apply to other things in our life, we cannot apply it to being a fertility patient, right? So it's not like one of those things where if I work hard enough, if I take enough supplements, if I exercise enough, if I have enough money, education, and see the best doctors, then it's going to work. And That's the thing. It doesn't matter who you are. It doesn't matter how hard you're working, what degrees you have, how much you achieved in your life, who you see as a fertility doctor or supplements you take or acupuncturist. It's either going to be there or not. So you almost have to let go of that control part of it so that you come out of it whole and not broken and triggered with all the things that worry me about being a fertility patient. It's not the long-term effects of things like cancer that I worry about. No, it's the effect of depression, PTSD, anxiety. That's what really worries me. So Jade, when you're going through all of this, having that perspective, it almost is freeing. It's like surrendering and saying, I'm letting go of the control. The only thing that you're going to control is the information you get during the process, so you feel like you're not overwhelmed or not part of the situation. So going in and asking those sparkle questions that I have brought up on the last 3 shows, including today, so you know what's happening and you're asking all the right questions as far as, what can I do differently? What else can I take? But the way I think about it is your cycle experience that you've had in the last 2 cycles are very typical for women who are at 42. So I would say it is totally acceptable to even try 2, even 4 more cycles. But just know that if at some point you're like, I'm done with it, it's okay. Like there's nothing you could have done better or different. You've done everything you possibly can with what you have. So this next question is from Elle. Elle says, hi, Dr. Aimee. I've been listening to your Instagram live sessions and I've been learning so much. I am 40 years old in good health with an average ovarian reserve, AMH of 1.2, FSH of 12, 9 antral follicle count, and a completed Tushy method test with normal results, but no endometrial testing yet. So first of all, Elle, I would say that your levels are better than average for someone who's 40. I wanted to freeze my eggs, but I was told that I should do IVF next due to my age, so I'm planning on starting IVF with donor sperm next month. Elle, I think that's a great decision. So figure out what your eggs are going to turn into as embryos, and then maybe consider more egg freezing after that. My plan will be to start mid-cycle with estrogen, then the cycle after, starting on day 2 or 3, I will take Clomid and 1 shot each of menopur Sazin for 10 to 12 days. How many eggs and embryos do you think I should get with this plan? I assume this is the most aggressive plan. Do you agree with it, or do you have other suggestions? Is Clomid better for me? I trust you, and thank you for choosing to answer my questions. Okay, Elle, let's go through. You've already had the Tushy method. Let's talk about the egg whisperer diet, okay? So the D is diagnosis. We know your diagnosis is, it sounds like you're a single mama by choice. Awesome. It sounds like your age is a factor. Being a single mama by choice, let me tell you, is not a factor. It's an amazing, wonderful thing. But as far as 40 years old, your ovarian reserve is really good, but we got to talk about those 2 things, being practical and pragmatic, and knowing what the third P, PPP, the third P is your pyramid. Like, what is your pyramid going to look like? And I know that's the question that you're asking me. And so what I would say, we go into it saying we might be lucky enough to get 1 healthy embryo since you're 40 with the levels that you have, but we have to open to all possibilities that we might need other options to help us grow our family. So sometimes when you do a cycle and you learn that there's no embryo to transfer, that can be really, really overwhelming and really sad. And I have those emotions too with my patients because I'm the one that makes those phone calls, and those are really, really hard phone calls to make. But long story, even longer, I would say, be open to, doing the work and consider several cycles if that's something that you're open to. And I would be as aggressive with your stim as possible, especially for the first cycle, to see if you can get at least 10 mature eggs to grow. In your protocol, it sounds like that is something that your doctor is doing for you. If you were a patient of mine here, I would not ever add Clomid. I hate Clomid. I use Femera. And I'm very adamant about that because of the side effects and how it raises our estrogen levels. The other thing that I would use is HGH in your protocol, and make sure you're taking some of the supplements that I've talked about if that's something that your doctor agrees with as well. So this next question is from Geraldine. And Geraldine says, hi, Dr. Aimee. I just turned 33. I had to go on chemotherapy because of lupus nephritis when I was 17 years old. My husband, also 33, did a full analysis, DNA fragmentation testing, said all his labs were good. His DFI was 22%. This is the thing. We had to do IVF because of his low count and motility. The doctor got 10 mature eggs, 9 fertilized, but on day 3 we had 6 and none turned into blastocysts. The doctor said it was egg quality, and I've been researching, and I think I might have premature ovarian failure from the chemotherapy that I took. Geraldine's asking, is there a way to test for ovarian failure? Are there any treatments for it? Would our only option be egg donor? And if we go the egg donor route, is there a time limit like there would be if I was using my eggs? My husband may freeze sperm. So Geraldine, this is the thing. There's no such thing as an egg donor emergency. It's nice that your doctor is just talking to you about all possible options. But premature ovarian failure is truly when you've gone through menopause. So you're 33. Your doctor retrieved a whole bunch of eggs and got 10 mature. So we know you don't have premature ovarian failure. So if you were a patient of mine, I would say to you, this is why I think it's egg quality. This is why I think it is not sperm quality. So ask your doctor those questions. Why do you think it's egg quality? Why aren't you saying it's sperm quality? Because we know that he has low count and low motility. And what have you done to prove that, right? So you did the DNA fragmentation test, but is there a varicocele, right? Are there supplements that your husband can take? Is his testosterone level low? Have you truly looked at everything that you could possibly look at? Like what's in my balls method. I just said my balls. That's really funny. So go to ballsmethod.com and you can learn about all the things that I would do for you if you were a patient of mine, if a husband or partner had low count and low motility. So that's something to think about because I've had situations where people jump to egg donor and then the same thing happens with the embryos. And you don't want to be in that situation where you learn this lesson the hard way. You want to learn all the lessons before you go through another IVF cycle. So that's what I would suggest for you. Okay, so this next question is from Yvonne. Yvonne says, most people with stems, they can grow follicles, but I happen to lose them. I'll give you an example. Baseline, follicle count 13. By day 5 or day 6, the count's around 7. This has happened to me 3 times. What is the issue? I've done low stems and high antagonist protocol having the same results. What can be done? I'd like to bank more embryos. I have a low AMH. Why do my follicles not stimulate? Help. So Yvonne, I have to break it to you. You're not that special. You're normal. That's called being human. I swear. Promise you. So if there's someone out there that's making you feel like you're not normal, I got a surprise for you here. You're totally normal. So if you look at my pyramid, the pyramid doesn't go from here from the very beginning. The pyramid goes up like this. So as you go up that pyramid, the numbers go down. So I always tell patients, I don't give them the expectation because people ask that. They say to me, Dr. Aimee, so you see 5 follicles, so does this mean you're going to see 10 by the end? And I said, aha, let's talk again about your pyramid and what your pyramid looks like. So 5 follicles can be 3 mature eggs, can be 2 fertilized, and maybe 1 embryo, right? So talk to your doctor about that because not every follicle will have a viable egg and not every viable egg will turn into a mature one that's going to turn into an embryo, yada, yada, yada. So Yvonne, great question. And the thing is, guys, I totally get it. I get it when you see a certain number, I'll tell you, I'll give you an example. So the other day I had a patient, I told her she had 9 follicles, okay? The next visit she came in, there were 8. And I'm excited. Oh my God, 8 grew from the 9. This is awesome. So I'm sitting there woohoo, I'm so excited. I'm dancing on my little unicorn pole, acting like the unicorn that I am, so happy. And she says to me, what happened to the 9th one? And I'm like, what? What do you mean what happened to the 9th one? This is awesome. We start with 9 and there's 8. That's incredible. And so I'm constantly learning these lessons. I already learned the lesson, but I'm constantly learning these lessons that it's so important to make sure patients know that their feelings are valid. I get it. I said, I totally get it. We want 100%. Every single egg we see on ultrasound is a chance for a pregnancy. So no one wants that to go away. But it's just normal biology. That's just what happens. It's called being human. So now I'm going to answer a question from Molly. Hi, Dr. Aimee. I'm 38, and thanks to your advice, well, this is really sweet, you guys. I have a sweet 7-month-old baby boy. That's awesome to hear, Molly. Thank you for sharing that. We now find ourselves feeling really greedy and wanting one more. Well, I have to tell you, Molly, greed doesn't mean being a parent, especially nowadays. So it's the opposite of greed if you want more kids. Let me tell you. Background is this. We did 1 full cycle, 10 eggs retrieved, 0 fertilized, no ICSI. Then I contacted you and you led me to Hope and Dr. Zyman. That was 2 years ago. Levels were AMH 1.6, FSH 6.9, estradiol 46. We had 16 eggs retrieved, 13 fertilized with ICSI, 8 made it to day 6, and only 2 chromosomally normal. First one we miscarried, and now the last one is the love of our life. We have a consult in a month to maybe start another cycle. Since I'm breastfeeding, I probably can't get my levels checked. Is that true? Curious what you might think those could look like. What supplements and type of cycle would you maybe suggest for one more child? And we've drained our savings on the other 2 cycles, so wondering if there's a more inexpensive way to go about having one more. Okay, Molly, so this is the thing. Remember, diagnosis before treatment, and we know it seems like there's a fertilization issue. With that being said, it seems like using ICSI to help you guys get pregnant is really needed. So I'm really hoping that one day, like I can send in, I just imagine this little sperm cell, and I can attach a little like robot to the neck of the sperm cell. And then I can have some little type of like AI device thing where I can guide a sperm up into the tube, into the egg, and then make the sperm fertilize an egg. But until then, we have ICSI. There's no sperm bot that I can send into your fallopian tube to fertilize the egg. So I really feel like, you can perhaps like look at the DNA fragmentation and see what that is and go through the balls method and see what's going on there. But at the end of the day, it seems like doing ICSI probably makes the most sense, and going through IVF again is what I would recommend as well. With 16 eggs retrieved 2 years ago, I still think there's probably a pretty good chance you'll probably get between 8 and 10. So I think your fertility levels will be pretty good. It might take more than one cycle to get one normal, but at 38, having had 2 normals 2 years ago, I would predict you would probably have 1 normal per cycle moving forward now. That's kind of my guess. But I would say, since you're breastfeeding, sometimes doctors, and not all of them, tell patients you have to stop. I actually, if you were a patient of mine, would tell you it's okay to keep breastfeeding as we're doing these evaluations, as you're starting the medications. But certainly talk to your doctor specifically about that before you do that. And the supplements like CoQ10, and I don't worry about that affecting your breastfeeding or your sweet 7-month-old baby at all. But I would say, do a similar cycle that you did 2 years ago, and I would bet that you might just need a higher dose of medications just because of the passage of time, but otherwise you would still have a pretty good chance of pregnancy and getting another healthy embryo 2 years later. So thanks for writing in, Molly. This next question is from Alex. The question is, for beta-3 integrin testing, what are the options if you don't ovulate on your own? What is the treatment if negative or low? What is the success of IUI after treatment versus IVF? Okay, so Alex, I don't do beta integrin testing. And why is because I like the ERA test. I don't need to look and see if beta integrin is not absent. I want to see exactly how to time things so that implantation will occur. And especially if you're not ovulating, well, that's what the ERA test can do. You do the mock cycle, right? You take hormones to mimic ovulation, and you do the biopsy on the right day. So that's what I would suggest for you. So that's the test that I use now, and I've used it since 2010. I can't believe it's been that long. So this next question is from Brooke. Brooke says, I'm 29 years old, initially anovulatory, now unexplained. First round of IVF canceled due to poor stim. Next cycle, increased gonal F to 300 with 150 of Menopur with 21 days prior with testosterone. Retrieved 11 eggs, ending up transferring 2 on day 3, which failed. Have 1 frozen day 6. We are going ahead with the ERA, then FET. If we end up having to do another retrieval, what would you recommend doing differently? All of my labs are normal. Thyroid's normal. Husband has normal sperm. AMH is 3.4. No explanation as to why I'm not responding. Previously did 3 IUIs with tamoxifen with a good ovarian response and AFC counts of 5 to 10 with AFC rounds, AFC only 2 to 4. Also, when do you think it's time to move clinics for a second opinion? Okay, Brooke, so I'm wondering if all of the testosterone could have suppressed your ovaries too much, and that is what made it harder for them to wake up. My suggestion at 29 years of age is to maybe do another cycle now rather than try with this embryo and then hopefully you get pregnant, right? I mean, like, that's what we all want. But if you do, or when you do, and you're ready to have another baby, it might be just so much harder to get an egg to grow at that point, given everything that you're going through. So it sounds like the diagnosis is egg quality, and the question is why. So could it be genetic? So I would make sure you've done a chromosome analysis, do a Fragile X screen. And I wish there was a genetic variant test for things like this, like certain genes that you might have inherited that can cause eggs to do this. But unfortunately, there isn't. So doing a chromosome analysis and Fragile X screen and taking all the supplements and making sure you're in the healthiest version of yourself, consider acupuncture. Talk about all the same things on the sperm side, but if you were a patient of mine, I would consider a mini IVF cycle, adding HGH, and no testosterone priming is what I would recommend. So that's kind of my suggestion. And the time to move on to another clinic is anytime. So there's nothing wrong with just getting more opinions, talking to more people, getting different perspectives. This is such a big deal. So you really want to feel like you're being listened to and heard. And even if you go to another clinic for another opinion, you can still go back to your original clinic and do IVF with them if that's what you choose. So last question that was sent in for today's show, and then I'll go through all your chatted questions. And this is from Melissa. Hi, Dr. Aimee. I have 2 beautiful embryos, a 4AA and a 4AB minus, and I'm now trying to decide between a natural FET or a medicated cycle. I previously used Clomid and Letrozole in unsuccessful IUIs. After my period started, I had an elevated hormone panel which showed progesterone rising again, even though I was bleeding. It created some delays. It happened using both medications. My doctor said sometimes it happens, but it was very unusual. However, normally, without any ovulation stim, my periods are always right on time. I ovulate regularly, and I always usually have a lining of 10 millimeters. But I was really hoping for a natural cycle without having to put hormones into my body. But my doctor believes with my history, a medicated cycle would be a better option, and I plan on talking to him in more detail on this, but I really wanted your opinion. Thanks for all you do. Okay, Melissa, this is really awesome. You have these 2 gorgeous embryos, and let's just go through the 3 questions. What do you want? What's it going to take? And are you willing to do it? So I don't know how many kids you want, and I don't know how old you are, and I don't know if you have any other babies at home. So this is the thing that I would talk to you about if you were my patient. I would say, look, let's just go through this scenario. It can happen. You thaw an embryo in 2 years and it doesn't survive. And let's say if you're 41 years old right now, well, it might be really hard to get more embryos. So we might want to talk about, let's do another cycle now and just get more so we feel really comfortable that we've secured more options for you for the future. The other thing is listen to your gut, listen to your ovaries. If you really want to do a natural cycle and you feel that's right for you, do it. And then you can also run yourself through a mock cycle, right? So you monitor your natural cycle for a month first. You don't necessarily have to do the ERA or Receptiva test, but monitor your natural cycle. Go in when you're ovulating, check your hormones, and then go back when you would have done the transfer. Check your hormones, look at your lining, and see how things go. Then learn more about what happens after you would have done the quote-unquote transfer, and then see how many days your luteal phase was, and then say, was this enough to support an embryo and a healthy pregnancy? So you don't necessarily have to make any big picture decisions right now. Don't feel rushed or overwhelmed with something that you feel like you have to decide upon right now, because you really don't. So you can really take your time, learn more about your body, and then transfer the way that you feel is best for you after talking to your doctor and see if they agree as well. Okay, guys, I'm going to go through your live chatted questions, and then let's start. I'm going to start from the top. And then let's go down. So the first question is, hi, Dr. Aimee, does it matter? Ooh, I just punched myself. Did you guys see that? I just punched myself in the face. I'm used to punching myself in the nose because it's so big. It gets in the way all the time. But my chin, I didn't notice that it was that big. I forgot that I had a chin because I'm wearing the mask all the time. Hi, Dr. Aimee, does it matter if you haven't had your FSH estradiol check before injections retrieval? The AMH is 4 with 20 follicles. And I would say, Michelle, I wouldn't sweat it. I mean, you're not going to do anything differently with the results, right? I mean, you're still going to move forward. You have a fabulous egg count. So even if your FSH was 15 or 20 even, you would still go for it. But I like to have an accurate set of expectations for my patients, so I just check it with the start of their cycles, but it doesn't mean that you have to. Next question is from Padmasana by the Bay. Okay, hi, Dr. Aimee. What do you say to someone with unexplained infertility who's scared to go to IVF and have it failed because the true cause hasn't been found yet? How do you know if that's the right move? So what I would say is if you haven't done the Tushy check, the 5 fertility tests that you can do to get to a diagnosis, do it and really make sure you've done it. Like I have patients that say, well, I had my tubes checked. They did an ultrasound. They looked good. I'm like, no, that's not really how we make sure the tubes are open. Or they say, well, I had a pap smear and so my doctor said I didn't have endometriosis. I'm like, no. Or fibroids. That's really not how we find out if someone had fibroids or not. Or my favorite is, yeah, we did a semen analysis, but the sperm was low, but they said it was fine, so it was fine. And they told us we have unexplained infertility. I'm like, that's not really how it works. So do all the tests, go to a doctor. And at the end of the day, sometimes when everything looks perfect, you can still learn through IVF that you may not have mature enough eggs or they don't fertilize or they stop growing, just like the situations that you've heard about on this show and the scenarios that I've read about. So you just have to be prepared for all possibilities and reserve a part of your heart for that possibility that a cycle might not be successful and may not work. So at the end of the day, you have to think of it as work, and you can't take it personally, right? Like if you have like a heart condition, you go to the doctor and you figure out what's going on and you fix it. But when it comes to fertility, it's just so scary to think that, something could be wrong and that you can't fix it. And I totally get that. It's just such a personal thing. So next question is, do you think doing the FET right after the ARIA is a good idea? And my answer is yeah. There's no rush either. You can do it now or later. Next question is, are there any ways to predict egg quality? I'm 40 and my first baby was stillborn 6 months ago, and all I want to do is get pregnant again and bring home a living baby. I'm really sorry. So the thing is, your age is the most reliable predictor of egg quality. And then we look at the AFC, AMH, and FSH and estradiol. We put that all together and we come up with your IVF pyramid and ask your doctor to do that for you. And I'm truly so sorry that you had that experience and you had a stillbirth. So this next question is, hello, I'm 37. My AMH is 0.18, FSH 11. I've been on high-dose gonal menopur omnitrope, which is HGH for you guys who don't know. And I've had 3 follicles that were empty, 2 had an egg. I've been on CoQ10, DHEA, vitamin D. What protocol would you suggest? So I would say amazing. Like your AMH is 0.18 and you had 2 eggs, like do the same thing. Like literally, do the same thing. However, I don't really like high doses like that. So if your doctor is open to trying a mini IVF protocol to try and get 2 eggs, that's kind of what I would consider doing. And I'm not a big fan of DHEA, so let me swallow the frog right now. Please hold. So consider checking your testosterone if you've been on that DHEA for a long time. So next question. Hi, Dr. Aimee, I'm 37. I have endometriosis. Would I request an ERA or should I wait until my doctor offers to do one? So you guys, the Egg Whisperer diet is diagnosis, IVF, endometrial testing. That includes the ERA test and endometriosis testing, and then transfer. So, go through these steps with your doctor and ask them, have you ruled out endometriosis? Does it make sense for me to do an ERA test? What would my chances be if I did the ERA, and go from there? I have lots of really supportive messages, and thank you guys so much. Next question is, my lining check today is 11 millimeters. My estrogen level is 439. My transfer is scheduled for next Friday. Is it normal to continue 4 patches when it's that high? I thought they would reduce it. Thanks, doc. So, 4 patches is something that I go to, but typically if a patient of mine had a lining of 11 millimeters, I would drop the estrogen patch to 3, and I usually peak at 3. And then I go to 4 if the lining isn't quite where I want it to be. Then I up it to 4. But the strategy that you're using is totally fine. An estrogen of 439 isn't too high at all. As long as you can tolerate the patches, I don't see a reason to decrease it unless you really feel like you're symptomatic and you don't want to be on that high of a dose. But it's not that high. It's still pretty darn reasonable. Next question is from Aimee. I have a stage 2 endometriosis that I treated in 2013. Having endo symptoms and wondering if a laparoscopy is a good idea before my transfer. And the answer is yes. If you're having endo symptoms, I would strongly suggest doing that, or at least talking to someone about it. Next question is, hi, I'm 26. My FSH is 10. My AMH was 2.9 in August, and this month it's 1.9. Had my IVF retrieval today, got 10 eggs. My doctor said some were empty. Should I be concerned about DOR? So, I wouldn't be concerned about DOR. Don't label yourself. Just thinking of yourself as having young, healthy eggs at 29. You're just doing the work that you need to do to build your family. So I hate labels like that. It just makes me sad. So next question is, hope to be a mom. Hi, Dr. Aimee. My second FVT is right now. It's my first time seeing a double line, although it ended up in a chemical pregnancy. I'm sorry. Am I too optimistic to be a little happy that I can finally be able to be pregnant? And you're not. Again, that's part of being human is being trying to find the positive in every experience. And you have to. And I think it's okay to be excited about the fact that you had a pregnancy, even though it wasn't a healthy one. And be sure to go through my angel method and angel workup to see if there's anything that you could do differently. I'll tell you some of the experience I've had. I've learned that, wow, the tubes now are filled with fluid and I couldn't see that on ultrasound. So maybe consider repeating an HSG. Or, wow, I did an autoimmune workup and you're deficient in protein S. And holy smokes, I'm so glad we detected it now. And now I know what strategy to use and maybe I'll add a blood thinner like Lovenox to your protocol to see if that can help. So talk to your doctor about all the things that they've ruled out to see if there's something that you can do to prevent that from happening again. At the end of the day, these things are completely out of our control, but it's definitely something to think about. So someone's saying, I'm 39, trying for 2 years, natural FET protocol. Should I consider blood clotting testing? And the answer is just trying for 2 years isn't the reason to. But if you have something in your family history, like your mom had lupus, for example, or your sister had recurrent miscarriages or some sort of autoimmune condition, or you have joint pain or something like that, then yeah, I would do a workup. So someone's asking, does mini IVF typically cost less than high stem IVF things? And the answer is mini IVF costs less because the meds cost less. And some clinics offer less cycles for less cost because there's less monitoring, less blood work for some mini IVF protocols. Next question, having an implant procedure next week, but the previous biopsy did not give any results. Should I be worried or is it something routine? I'm not sure what implant you're talking about. Next question, my doctor only likes vaginal progesterone. That's creepy. Sorry, I just had to say that. I missed one dose. Can we still trust the ERA result? And let me point out, there's nothing creepy about putting progesterone in your vagina, but I'm just wondering why they won't give you other options. So I think when I talk about progesterone, I talk about the vaginal progesterone as if it's Vagiseltzer. People have called it vagislime or vaginal slime. It's just like the slimy discharge that comes out. And it's gross. So I wish we had in the US what other countries have, which is a pessary. It's a ring that you just pop in your vagina and like you got progesterone. You don't have to deal with like the slime and stuff like that. Let's see here if we have any other questions. I do, but I want to go home and eat something. And you guys know my rule. Once my butt is asleep, I got to stop because now my toes are tingling. So thank you guys for putting up with me today. I think you guys are all fabulous and I love talking to you. And I love the fact that I got this really fun like stripper pole unicorn mug today. It just cracks me the heck up. So I hope you guys have a great night and I'll be here again because like I love coming on here and talking to you guys about all my fertility tips and tricks and embarrassing myself and punching myself in the chin and snorting and sounding like I swallowed a frog and I can barely spell. But that's what happens when you see patients all day long and love what you do and don't care or have any inhibitions about what you look like and what you say. So thank you again for coming and joining me on today's live. And I look forward to seeing you guys next time. And I hope you guys have a great night and I love you all. Have a good night. Bye guys.